conference. Okay, let's continue with the next conference entitled Nutritional Interventions in Extreme Premature Babies to Improve the Neurodevelopment with Dr. Waldemar Carlo, with the coordinators of licensed Jovita Plasencia, specialist nurse in newborn babies and upset neo, and Dr. Sandra Navarro, neonatologist and professor of the Javeriana University. Welcome. Continuing with the program regarding neuroprotection, we have Dr. Valdemar Carga, neonatologist, pediatrician from the University of Puerto Rico, and very well-known professor of pediatrics in Birmingham, where he develops research projects and is the director of the Division of Neonatology and professor in neonatology, perinatal, and pediatrics. Completed his studies in neonatology program, in research programs focused in lung disorders, ventilation, and reduction of perinatal death. He is also an investigator of Alabama and member of Inclusion, Equality, also of Alabama University. Welcome, and I hope that you will write down your questions. Thank you very much. Welcome and thank you. Thank you very much for your attention. As you heard, my research is in clinical studies, especially respiratory studies. But I am a mentor of Dr. Salas. He has really advanced in his career, but as a fellow in neonatology, I helped Dr. Salas, and now he teaches me a lot of things because I don't know anything about nutrition. So please don't ask me questions about nutrition. No conflict of interest. Very well, we're going to talk about the objectives. We're going to define the key concepts related to preterm birth, nutrition, and growth parameters, and the milestones of neurodevelopment. We're going to also analyze the current evidence among the relationship among the nutrition patterns and growth, and also to identify the good practices. You're going to see that not all have important effects, but you're going to see a lot of trends in which these practices are very good practice to be considered to optimize the growth first and foremost, and afterwards the neurodevelopment. So the idea is that in nutrition, optimal nutrition must stimulate growth and can strengthen the neurodevelopment in babies born on term and preterm. So one of the main objectives of nutrition is that the babies should grow in an adequate manner. We have certain rates of growth, and we know what we should expect. We're going to discuss these aspects, and we'll also discuss the corporal or body composition. All of these growth measures should be relevant or seem like intrauterine growth. Nevertheless, the metrics that we use, the measurements that we use for growth hasn't changed in many years, and maybe are not the best ones to use right now. Like ultrasound, we can see how the baby is growing, but not the quality of that growth. when we measure the circumference of the head, but we don't know if it's a good nutrition, and also some measures that are done on the next month. And a very important concept here we can see once the baby is born. Finally, there's a loss of physiological weight. But we know that, but sometimes we do not think about that in practice. Here we can see this curve that are for each gestational age, 35 to 24 weeks. And once the babies are born, they lose weight. So this is the physiological weight loss. We should not be concerned about that weight loss. We should try to optimize the nutrition, and I'm going to mention how we should do that to reduce the excess weight loss due to not very good nutrition. But after birth, the baby mobilizes liquids and going to lose weight, which is not corporal mass, it's liquid. Obviously, we need to optimize nutrition, especially the calories and protein, so that initially there's not much weight loss. And as we can see, historically speaking, we have used percentiles. We can see this graph with different percentiles. Traditional is number one is when the baby's born. We can see the percentile 1 to 50 percentile, and then we go higher until we reduce the percentiles again. We do not expect to go again to 15 percentile, 50, because the only effect of being born has a weight loss of liquid loss. So these graphs are in utero growth. We need to be aware of that. But the measurement that we prefer is score Z or Z. This score Z is when we take care of the patients. I need to raise my arms. Okay? The advantage of the Z score is a standardized way. One deviation of Z is 95 percentile. So it can be translated also into percentiles. But here we chose percentile or score Z. Okay, the reduction of 0.8 units in the score Z in weight during the 2 first weeks are aligned with physiological weight loss. Once the baby is born is what we expect. It will lose 0.8 or maybe a little bit less according to the optimization of nutrition. To moderate from severe is defined as a reduction of 2.2 units of score Z once they are born until the 36 weeks. So the objective is the baby should not surpass that. But important to consider these 0.8 units. After the discharge in ICU, we do not expect more weight loss. Once the baby is born, we can see weight loss, physiological weight loss, and maybe a little bit more after that. It was called extrauterine growth failure, but we prefer to use the term I forgot the term, sorry.
Sí, inglés. El nuevo, ahora se me olvidó, ahora va a salir por aquí, yo creo. Porque a veces la falla de
Sometimes
extrauterino
this failure in growth in uterus.
los padres no queremos decirle que está
We
fallando.
don't want to tell the parents that the baby is not growing.
Faltering.
In English, it's called faltering.
Español es como vacilar,
faltering. Okay.
Ajá, crecimiento vacilante, que es lo que
Faltering
se
growth.
conoce en español.
That's the term in English.
Y el término que se prefiere ahora
And the
para
preferred
explicar a los
term
padres
to
es
tell
una
to the
cosa
parents
quizás
is
transitoria.
something
No queremos
transitory. We don't
decirle
want to
está
say
fallando
something
ni
is
queremos
really
decirle que está vacilando en el crecimiento.
bad, but it's something that's slightly faulting in
Y
his
aquí lo
growth.
vemos.
We can see it here. It's
Una
faulty.
vez tenemos ese ajuste de
Once
peso
we
que está por
had the
nacer, vemos la comparación
weight
entre la
adjustment,
tasa
we
de
can see
crecimiento neonatal
the
e intrauterino,
comparison
que se
among
vuelve más
the
grande. Si vemos aquí
different
como hay
weights. We
la
can
misma
see
caída
the
que
same
se ve
drop
aquí de
here
peso
in
al nacer en los prematuros,
weight
tiene caída también
when the
porque
babies
tiene
are
más
born.
peso, como todos sabemos. Así que el niño regresa a
So
ese
the baby goes
crecimiento
back to the normal growth
postnatal.
afterwards.
La composición corporal se
The
reconoce
body
previamente como un
composition is
indicador
known as an
superior a
indicator
la obesidad en comparación con el
above the
índice de masa
IBM
corporal en bebés prematuros. O
in
sea que
preterm babies.
hay que ir
So
pensando
we need to
en la
think
composición corporal
about the
y no
body
solo en el
composition,
peso.
not
Y ya
only the
van a ver que
weight.
en la
You're
investigación
going to
ya
see
se
that
hace
in
mucho con
recent
la investigación,
studies,
se hace masa corporal
it's done
y
by
composición corporal.
IBM
No quiero decir que en la
and
clínica tengan que
body
hacer,
mass.
pero cuando vean los
But
estudios
when
de
you see the
crecimiento,
studies
deben
in
ver
growth, you
también
also
cómo se
need to see how
relaciona
it's
ese
related,
crecimiento
that
en peso,
growth
ese aumento de
in
peso,
weight, that
aumento
in weight,
en la
increase in
longitud,
weight,
cómo se compara
how
con
is it
la
compared
composición corporal.
to the body
La
composition?
susceptibilidad de alteraciones
Susceptibility
metabólicas tempranas exige una
of
evaluación
metabolic
cuidadosa
program
de los
in an
resultados
early
tanto
stage
cuantitativos
demands
como
a very
cualitativos del
careful
crecimiento.
evaluation of
O sea que
results,
no es solamente
qualitative and
requisito
quantitative in
cuantitativo,
growth.
es cualitativo.
This both are very important, quantitative
Eso
and
nos ayuda con
qualitative.
la
This can help us
composición corporal,
with
como
the
se
body
define aquí.
composition.
Este es el tipo de aquí abajo.
Here you can see these images.
Aquí este es el tipo
This is
que
the
se usa para medir
peapod used to
composición
measure
corporal. Y
body
como ven,
composition.
menos invasivos, más fáciles de
It's less
implementar en
invasive
la
and
clínica.
easy to implement in the in
Como vemos
ICU.
aquí, se puede hacer
It can be
en paciente
done
estable, la
in stable
composición corporal se puede
patients.
medir
It can be
con
measured
resonancia,
with
como vemos aquí,
MRI, as you can
con
see here,
densitometría
with
y con
DEXA,
Inverted Displacement Plethysmography,
and also with the ADP.
todas las otras medidas que se pueden utilizar.
These are all devices that can be
En
used.
prematuro agitado
In
crítico, la
preterm and
composición
critical
corporal se
states,
puede medir
the body
con análisis de
composition
biopsia del
can
bebé,
be assessed by
menos
BIA,
invasiva,
less
no hay
invasive.
que hacer tanto esfuerzo como
We
el
don't
peso.
have to do
Y
much
tenemos
more
que
effort.
compararlo
This is a very low
también
cost
enseñanza de
device.
ultrasonido y de creatina
Ultrasound also
que se pueden
and
utilizar para
decreating,
medir
and that can be
composición
used
corporal.
to
En
measure
la
body
práctica,
composition in
en
practice.
Estados
In
Unidos
the United
no se
States,
hace esto
this is
todavía.
not done.
Claro sobre eso. Esto se hace con
This is done
investigación.
through
Pero
in
se lo digo
research.
para que
But I just
también
wanted
cuando
to
vayan
let you
a
know, once
literatura,
you read the
vean que
literature,
no
that you can
solamente
see that it's
medir
not
la tasa
only should
de
analyze
el crecimiento
the
cuantitativo,
quantitative growth,
pero también el
but also the
cualitativo. La
qualitative
correlación entre
growth.
masa
The
libre
correlation
de
among free
grasa
mass
medida mediante el ADP y
measured
la
by ADP
fosfatasa
and muscular mass,
proveniendo del
measured through
tetraamina
D3
empoderada.
creatine is
Cada
moderated.
uno de
So
estos
each one
equipos
of these
describe
devices
un poco diferente
measures a little bit
la
different
cualidad del crecimiento.
the growth.
Como vemos aquí, la masa
Here we can
libre,
see
masa libre
fat-free
de
mass
grasa y la masa muscular
and
hipertrófica
muscular
son
mass are
conceptos
concepts
relacionados pero distintos
related,
en la
but without
composición
different
corporal.
in,
Se
but also in the
relacionan
body
hay una
composition.
correlación, pero una
There's a
correlación
correlation, but
amplia.
not a direct one.
There are key growth indicators as weight. We can see grams per kilo per day. Also, the increase in the length that is extremely important. And even we can see that this is one of the measurements that it's better related with the neurodevelopment when the kids don't grow and they don't grow in length. We have to be very worried because nutrition it's not enough and it's associated to neurodevelopment issues. And And we can see that the arm circumference can also predict the percentage of body fat, and and that's why we are seeing that the premature babies that were born alive, that we can define the optimal body composition. And therefore, this is how this is correlated with the C score and with the current weight difference. We can see that it's not a perfect correlation, but it's relating and one with the other. And here we can see the follow-up of the absolute weight of free fat mass regard instead of the C scores that can offer a better approach for the follow-up of the body composition. And therefore this has been seen between 34 to, this is how we can show in the x-axis, it's the difference in the current weight and the the growth goals, and how it is related to the fat-free mass. And this is when we compare the fat according to clinical variables. These are clinical variables for the adjustment that it's done. And that's why that neurodevelopmental disabilities are defined as a group of disabilities that sometimes it's done through the Bailey scale, but also other assessments like the cognitive disability, motor disability, that it's where we use the GMFSS, and also the sensorial disabilities or the hearing and visual disabilities. Now let's go to the second part of my talk, where I want to emphasize the current evidence about the relationship of growth patterns in neurodevelopment. This is a study done by Dr. De Salas and myself with more than with thousands of patients, and we had a 2-year follow-up. After 2 years of life, here we can see that the analysis includes 5,393 patients, and where we are compare it with the intergrowth growth curves, and we can see how these babies grew. These were extremely premature babies, and from 24 to 26 weeks. I think that these are some of the smallest ones you take care of us. So keep this in mind. I know that some centers are treating them 23 and even 22 weeks. I know there are some centers that are doing that because little by little we keep reducing the gestational age, but we can see that they are highly representative of the most immature patients that you are going to have in your daily practice. And as we can see here throughout this 11 years, we can see how we can see the failure in growth. And but now, but therefore we can see validated. But we can say we can see that the babies are growing better. This is from the Neonatal Research Network, which is a multicentric, and these are data that are reliable. And therefore, we can see that cognitive disability, as we can see, and this is not reducing the disability, and that they are associated and with less disability. But it's not that as a group we are reducing the capacity. Therefore, we can see that there are opportunities to, and therefore there it's a graph that it's important, which is the CART analysis. The CART analysis tries to identify what are the most important and that with disability. And as we can see the length, the C, the Z score. It's what we are able to see that the association, if the Z score reduces more than, we can see it's less -1, that it reduces one or more. This is -1 if this is associated with cognitive disability. Therefore, if we have a kid that it's not growing well throughout the length, this is the kid that we have to think that it's a higher risk of disability. And therefore, the second thing, it's the head, the cephalic growth, the growth of the head. And we can see that the analysis, okay, to CT scan analysis, it's that say we can include all the data. We don't add absolute limits of, but what we think it's important. And we can see that the CAT analysis determines that limit, and that in the case of the longitudinal growth, we can see that it's worse than less 1 in the case of, as we can see that we compare what it happens at birth. If they have lost the C score, if we can see that it's less than 2.4, it's less than at birth. There's a small head growth, and therefore we can say that there it's an absolute, the length it's more absolute regardless of how the baby is grown. The cephalic growth depends on the head, because some babies by genetics they have a bigger head. That's why we have to correct how the head was at birth. We have seen all the data, and we can see all the data, how everything I have explained about how the head circumference and the length are are associated to cognitive issues in neurodevelopment. We're going to identify certain practices in our ICU. We've started doing studies since the 90s, where we were able to see that we didn't have to keep the babies without oral food for 1 or 2 weeks like we did in the past. Now we start feeding them since the first day of life, and what I am going to explain. And when we compare, we are the one of the first ones that take the babies to complete nutrition. At least, and these are in babies extremely premature. We give them complete feeding. We can see that it's half of the days that is the average in the United States. And therefore we're going to start we have to start in acute nutrition, which is very important, because for during the first 2 weeks we develop, there are some nutritional deficits that are accumulated and that are difficult to solve. That's why a lot of the focus that I'm going to teach is that during the first 2 weeks we need all the interventions that can be done during the first 2 weeks, and then we have the convalescence period, which is up to 3 months after birth, 90 days. These are 90 days when we add the breast milk fortifiers. So what we do is that we increase 170 to 170 per kilo. Sometimes they reach 200. Sometimes at least 5% of the time. And I'm going to show you some data that show that the babies tolerate 200 cc's by kilos, and we offer the premature formula for premature breast milk. It's not enough after the 34 weeks. And we also use very special formulas after discharge. And how do you use to use somebody here uses a special formula after discharge, okay, like 10%. We try, we up to 52 weeks, more or less. If the growth, it's okay, but if not, we continue it even more. But I don't know if you have this advantage that a premature formula are free. I don't know if this happens here, but a big proportion it's for free. All these kids all qualified for special milk during their first year of life. Protein deficit, it's a risk factor for suboptimal growth. Here we can see the protein intake that it's very low, especially during the first day. It's very low, especially the oral protein. It's low, and that's why we have protein at birth. I don't know how many. Who starts protein? And now you'll have to raise your hand. Who initiates protein since the moment of birth? Raise your hand. Who initiates protein since the moment of birth? Okay. In the U.S., there is the concept of vanilla TPM. Vanilla TPM, it's protein with glucose, and that's why all these kids get the same solution. Some centers says, okay, who adds 2 grams of protein per day? Who administers 2 grams of protein per day? Okay, 3 grams of protein per day, and the 4 grams. 4 grams. It's it's been seen that 4 versus 2 was comparable. There was no problem. Therefore, our solution has 4 grams of protein per 100 cc of glucose at 10%, and that's the standard. And we never have 100 cc per kilo. To these kids, we add less, and we can see 2 or 3 grams of protein. And I think that it is a very important and easy, and it's not as costly as the TPM. And okay, it's not as costly as the TPM. It's not more expensive than glucose at 10%. It's rather expensive, and it's ready for the patients when they get into the NICU. This is what we added to the babies that are under 30 weeks. They do that, and it's the same. This acquiring protein, and therefore you can see that here, and they are getting milk. And I think that this is important to. It's an easy intervention. And I am going to teach you some studies that we have done. Dr. Salas, it's an author of these studies. And over here, we wanted to compare 140, 160, that at least in the US it's very common. There is a survey that was recently published. We can see that almost all the centers, the maximum that they reach is 170, 180, and we compared 160. Sorry, 140, 160 versus the intervention 180, 200. We compared both, and for you to understand it, we can see we increase it to get it to 200, and when the weight is lost, when they keep on increasing the weight, it goes to 185, and we start again to 200. And therefore we can see that the goal is 200. In this study, we did it that way, but we were able to achieve was 180. I am going to show you part of the study, because the study was able to show a better growth and a better length than 180 patients. These were premature. And these were premature babies, not extremely premature, but almost up to 32 weeks. And as we can see over here, there's a huge volume difference. It's almost 180, and therefore we didn't want it to go to 140. It keeps on growing, and we can see how we can see, and they see it well. If they don't tolerate it well, they couldn't increase to 200, and therefore there was an increase in body fat that was less than 2%. It's acceptable, and therefore here it says 15 and 2%, and there was an increase in the mass, and we've been doing multicentric studies right now. and therefore and therefore that I've been doing. I was able to see with these patients many of these measurements that I'm talking about. Another intervention that we did, it's to receive a fortified milk with hydrolyzed protein, and therefore the two kids, and therefore we can see that the intervention group. And as we can see, we can see the increase of the internal intake of protein improved the fat-free mass in the areas where received protein enriched milk. That's why we can say that it improves the body mass. And this is another intervention that can't be done, and that's why breast milk doesn't have enough protein. And even if we added the fortification, the protein, it's not enough. That's why, and that's why we can see if the baby is growing, we need to add protein. The fortified protein enriched milk didn't improve neurodevelopment, but I wanted to clarify that we are doing a follow up of these babies. We do this, and therefore, and there it's not powered. And therefore the number of and the number this is not done for neurodevelopment. These are studies that we're going to do later on, but we can see what interventions can be effective, although they are not studies done for that purpose. And to add breast milk after birth can improve the growth of this baby and the accumulation of fat-free mass in extreme premature babies, adding protein in this case. Another intervention is if we start the human fortifier at an early date, to start on day 3 versus non-starting an early fortifier. Sometimes we are afraid of supplementing with bovine. That's why we are afraid of such an early development. Here we started at the third day of life, as we can see over here, day 3. And over here we can see the concert 128, a small study, 128 patients, and with the growth measurements. And over here we can see that the groups were different because we are doing smaller studies, and we can see that there were smaller babies, smaller for the gestational age at birth in the intervention group. That's why and I'm gonna show you the adjusted outcomes, and for female babies it was different as well. Here we can see the characteristics of the patients, the feeding practices during the first weeks after growth, and we can see that the nutrition, there was no differences in nutrition, but there was no differences, and there were no complications. And we can also see the impact that increases the length, and it reduces the z-scores in the cephalic parameters and the premature babies. That's why the two measurements that I think are good for development are achieved with an early fortifier. And I think that this is another practice that we should consider doing, and maybe in a couple of years. Now we're going to do volume, and then we're going to do this multicentric study in the US. That's why we are preparing ourselves. Here we see a lot of significant differences. Therefore, and that include a better growth in these babies. Some of them were sicker, and we couldn't do a complete study. That's why I'm not going to talk about this. Maybe the early fortification on milk could have long-term effects that could be mediated by changes in the microbiota, and we can also think that that breast milk has many other benefits. Yes, we've been talking, I know I've been talking about growth, but there are many other things like the microbiota, and we also have the micronutrients that Dr. Embleton with that if we increase the milk from 150 to 200 cc, they are going to receive 33% more micronutrients. That's why we think that nutrition, it's not just our growth in weight, but we're going to have other advantages. And we can see that early fortification of breast milk is not associated to an in the outcomes in neurodevelopment and growth at 22, 26 months. As we can say here, this was only 80 patients that we were able to follow up. These are small studies that not necessarily we're going to say, oh no, no, this doesn't work on the long term. No, because we need to do bigger studies, but we have a follow-up study of all these studies, and we can also see the long-term benefits. And this is the study that we've just completed that I also think it's a very interesting study because we can see that one is the INET study. The INET, it's and they were randomized to 60 80 cc per kilo versus what it's currently done, which is 20 30 cc's per kilo on day 1 or 2 of life. At a very early stage, we initiated with 60 80 cc's per kilo of of donor milk or of breast milk, and we can see that the exclusive nutritional intervention can increase the length and can reduce the hospital cost. Therefore, don't worry, but because it's a bit expensive, but there can be some benefits. The premature babies in Enact Plus, what we did is that we add fortifier on day 6, and we can also see that there was a better protein intake. With the exception with the exception of the fortifier, what that means that there was no difference on the effect of the nutrition, and that there was no difference in the free mass score at day 21. But you can also see that it was a very short intervention, but it did improve the nutrition. To sum up, we can say that there are certain measurements that we need to consider, especially when we read research articles about how they would measure the weight increase. That it's not the quantitative increase, but also qualitative increase. And I've been able to see that weight increase, it's fat-free body mass, which is what we want. We can see that this is what these interventions accomplish. What does it mean that the nutrition that we usually do in our hospital, it's not optimal? And I can say that in a hospital, we've been more than 35 years trying to optimize nutrition, and it's still not optimal, because when we do this type of interventions, we can see that fat-free body mass, it's still improving. And that's why these are the strategies that can't be considered to be able to improve the growth and the quality of the growth. And also, we can also improve the neurodevelopment in the long term. Thank you so much. Thank you so much, Dr. Carlos. Thank you so much for sharing your experience and all your knowledge. And once again, let's open up. If there's any comment or question, go ahead, please. Good afternoon. Good afternoon, Dr. Guaricarlo. I have a question. When you were talking about the total volume of the 180 to 100 mLs per kilos of that premature newborn at 32 weeks, that volume, would you administer as a bolus or as an infusion pump? At what gestational age? According to your presentation, it was 32 weeks with a volumes on 100 and 200 and 104. And it said 32 weeks on your presentation. This is the bigger. This is with the bigger babies. We've done the studies, and right now we have 200 cc's per kilo. So this why we increase it little by little. Yes, with it through an esogastric probe, but we usually use a pump. Before we did it by using gravity, but you can do it anyway. It's the same thing. And the other question, when we talk about the impact, you talked about the protein and also the vitamins. And when we, according to your experience in what, because we usually use it between the second or third week. We add vitamins during the second or third week when the baby has enteral liquids, or can we use it at an earlier age? We are doing a research about vitamin D. We're going to do a study on vitamin D at an early stage, and another one on on vitamin D 800 international units. We're going to do a study about that. Dr. Maria del Mar Lopez did a study, a randomized study that was recently published, and was able to see that 400 units, it's great, and we can even increase it to 800 and of vitamin D at an early stage in our unit. And we haven't done studies of the vitamins, but we are rather aggressive, because when they get to a complete nutrition, 150 cc's per kilos, we initiate the vitamins. We can say that a week and a half of life, they are already using vitamins to the premature. We only give them half of the dosage of a term baby, and we also give them iron. And in analysis that they did, they were able to find we gave the best vitamins and iron nutrition without doing a lot of measurements of the ferritin, etc. Only with that practice. And a last question, and I apologize. And the usage of probiotics in premature in your unit. Do you recommend the use of probiotics in your unit? We would use it. We would use it until recently. The FDA in the U.S. said not to use them, but it's because of the product. Because the product it's not approved, and now there is a new product that it's proven that it's beneficial. As soon as they approve it, we're going to use it. As soon, doctor, I have a question. And when we talk about the curves, when we talk about the curves in one of the studies, you had intergrowth, and then you talk about Fenta. I don't know if you compared the Fenta 2013 to Fenta 2025, or if you've seen some kind of adjustment if we use one of the other of the curves.
This is multicentric. It was only that it has been improved, and these are very important centers in the United States. Does that answer your question? Did you compare, Fenton, with the new curves of last year compared to the ones that we used in 2013? Does it change a lot when we put the weight of the patient with the gestational age? We used like the intergrowth for you're using intergrowth. Oh, I understand. Good afternoon, doctor. Regarding your experience in your unit in starting the nutrition in these high volumes in the preterm babies and severe preterms, how the tolerance has been, because these babies present vomiting, or they has to be done left in the ICU, and that's why we may not advance. That's why we have an ascending curve. The nurses knew what we were doing, so it's normal for them to get worried, but it was no problem at all. We arrived to that volume quickly. It's not only us, it's been done in India. a similar study, but with bigger babies. But you can increase the nutrition very quickly. Good afternoon. Thank you very much. I have two questions. Hello, doctor. How are you? Regarding vitamin D, not sure if you're aware of that. Regarding to the values of vitamin D, normal in preterm babies, extreme preterm babies, what happens is when we dose the vitamin D in very small preterm babies, in less than 30 weeks, we found a very important deficit in all of them. We assume that there's going to be all of them with deficit of vitamin D. So in theory, we need to supplement extra vitamin D apart from the mother's milk. And regarding your work and the work presented, did you exclude those babies with bronchopulmonary dysplasia? Okay, the second question is easier to answer. They, they were treated before they didn't have dysplasia. The first week or second week, they were treated. We did the different interventions needed. They needed oxygen at 3 weeks. The high volume would include also the children. That's why we do. That's how we do it. Regarding vitamin D, you're right. What we believe in a normal vitamin level, the preterm babies are lower than the normal babies. So the recommendation has been to supplement vitamin D later on in life. We're going to do a study to be able to start with the first of 2 days of life with vitamin D. See, these are studies that we're planning next year, and you can also be part of it. It doesn't cost so much. Okay, a question before we end. There's always the fear of re-nutrition syndrome in the preterm baby when use protein high quantities. That can be prevented. How do you prevent that re-nutrition supplementation with just only monitoring high usage of phosphate from the beginning? Parental, that's what we use, high phosphate. Very good question, because the more you use the protein, you're going to have these problems, yes. I'm just curious. I would like to ask you, doctor, in these good intentions to do good assessment of the nutritional state, are there any articles where they talk about picometer in part of these assessments in this year? The picometer, the fat caliber, yes. We're not using that in children. Extreme or severe preterm babies. We don't use that right now. Following that line, doctor, how clinically can we approach to the free fat mass? I think it's a very good question, but I think the protein deficit that starts early on is one of the causes of low growth. So, protein early on in parental nutrition, they all have parental nutrition. So, in our case, we started 75 cc per kilogram per day. It's 3 grams of protein once they are born. And we believe it's very good. And the second day, they are breastfed, so we give them high volumes. We increase in a preterm baby, we have 70 cc per kilogram per day. So parenteral nutrition is a little bit reduced to 50, and enteral is really increased to 70. Day 2 after their birth. This is what we need to do, and that's the intervention needed. But how can we really approach to the growth of that baby in height and weight is free of fat?
Sí, ok. Buena pregunta
Very
porque
good
la
question.
carga clínica
Because in the
lo va a
clinical
cambiar
practice,
midiendo la grasa.
you're not going to be measuring fat,
La masa corporal, el body
the
composition,
body
el índice
composition.
de crecimiento. Si el niño se empieza a
If the
volver obeso,
baby starts to become
el bebé de
obese,
displasia
and many
va a
this
dar
happens
mucho
when
menos
baby have
actividad.
dysplasia
Eso es
later on
diferente.
in life. This is
Antes estaban
different.
naciendo gordos,
They are becoming fat,
ahorita el 75%
increase
ese
75
es el niño que
percentile.
empieza a
That's the
obeso.
baby that
El
has a
prematuro
problem. The preterm, the usual preterm, when we're okay in the first days of
no
life,
tenía ese
will
problema.
not have that
Así
problem.
que sí.
So,
El doctor Sala me enseñó
Dr. Salas
muchas
has
cosas
taught
que
me many things.
nace la gente con sobra
If
aquí no hay que volverlo a
above
repetir
75
porque hay que buscar
percentile, they
la
would.
pérdida
We
fisiológica
need to
de
think
peso.
about the
O sea que de los
physiological
60
weight
años
loss. If they
para
are to
arriba,
60, it's very well compared to the
entonces también
uh,
el crecimiento de la
birth
cabeza
at
y el
the
largo
weight at
va a
birth.
estar seguro. Me imagino que utilizar
I think that you use
el board,
the board measures, leg board.
ya, ya se utiliza en todos los centros,
It's
se
used in all the
utiliza para
centers,
medir
used
bien
to measure
exacto el crecimiento del
precisely
largo. Nosotros lo hacemos
the
todas las
growth.
semanas.
We don't do that every week, though. Okay, thank you very much. We have some questions online. One question is, you've mentioned during your talk several strategies to improve nutrition of the preterm baby. What do you think would be the most easier one to be implemented in our region?
Muy práctico, o
A
sea,
very practical way to answer that is mothers, usually speaking, produce more than 115 cc's per kilo per day. And if we help them at the beginning, they will produce a lot of milk from the beginning. I would say that to empathize
la leche materna
in
desde el primer
the
día
mother's milk on the first day and say to the mother, okay, your baby is able to eat now and you need to start feeding the baby. And we need to give that mother the idea of how much. I would believe it would be around 70 cc per kilo per day. There's a certain amount, a preterm baby of 10 per kilogram. Baby weighs 800 grams, that would be 8 cc. If you give me 8 cc, I'm going to give that to the baby right away. So the mothers know the objective. They know this is what they can be able to do. And if the next day they said, okay, I don't have more milk today, it's okay. It's okay. Don't worry about that. So first of all, volume early on, and then high volume. It doesn't cost a bit, nothing. It's free.
leche de la mamá. Claro, si vamos a usar leche donante,
If you're going to use donor milk, that's going to be a little bit costly. And fortify early on. As you saw in the slide that I said, early fortify can be started on the day 2 or 3 of life. There's no problem about that. We prefer the human, not the bovine.
somos bien agresivos con el humano, no con el bovino.
Not with the bovine. If only have bovine, you need to be very careful. Protein, supplemental, but I've given you some ideas of how to increase protein. And finally, the high volume, about 200. Don't worry, just put it as a test. But the guidelines in the United States and many guidelines in the world say 150 is full fillings. But the European guidelines say that 200 cc per kilogram. Okay, we have one more question. It's concerning the malnutrition in mothers and how it affects the health, neurodevelopment of the newborn baby. Malnutrition during pregnancy. How does it impact in the neurodevelopment of the baby? Malnutrition of the mother during pregnancy, yes. The baby really takes from the mother a lot of things. So even though the mother is not increasing weight, sometimes the baby is growing very well. But it's very important to speak with the mother to monitor the baby's growth. Before, we thought that if she increased weight, it was bad because that would lead to preeclampsia, but that's not being tested. So I'm pretty sure it's important to ensure the good nutrition of the mother. In Africa and India, they have used cookies for nutrition and fats, peanut butter. And they grow, and the mothers also increase weight and have better nutrition. Okay, we have a lot more questions. Unfortunately, we don't have much more time. Let's continue with the next presentation. Doctor, it was a pleasure to share this panel with you. Thank you very much for your presentation. Thank you very much.